Welcome to the ABG certification course. My name is Barbara Shepard. I'm a CN4 on 7 Saperstein, and I'll be talking you through this e-learning module.
The class will take approximately 1.5 to 2 hours to complete. My hope is that at the end of this course, you'll have a good understanding of the elements that make up the ABG panel and the physiological principles that determine their results. You'll also be given an opportunity to develop a systematic approach to ABG interpretation that will support a clear and accurate ABG assessments. Each participant will demonstrate the ABG procedure and receive feedback as necessary to ensure a safe and proper technique. So, the agenda will start with the ABG interpretation e-learning module, followed by a short break. When we return, you will watch another e-learning tutorial on the actual ABG procedure. After this, we'll take a short quiz and finish up with a return demo of the arterial puncture procedure. Once you've completed the course, you'll be given a form to document 3 successful ABG procedures. You can ask any certified provider on your unit to sign you off. Once completed, return the forms to your unit coordinator or secretary to place in your employee file, and this will complete your certification process.
Okay, let's get started with Part 1, Interpretation of Results. We will begin by simply talking about the elements that make up the blood gas panel result: the pH, the partial pressure of carbon dioxide, partial pressure of oxygen, bicarbonate, and finally the oxygen saturation. Some labs also generate a lactate and a base excess, but these results are not reported here at Cedars-Sinai. Of all the labs we get reported back to us as critical care nurses, I think the ABG is one of the more challenging to understand, primarily because it's a panel result, and it demands that you look at all the elements in relationship to one another to accurately assess what's happening with your patient. If you put the pieces together correctly in context with your patient's condition, you'll be on the road to selecting the most appropriate treatment option. So with this in mind, be sure you have a good understanding of your patient's underlying disease process as you evaluate your ABG results. One of the first questions you'll want to ask yourself when evaluating results would be, does the patient, or does our treatment for the patient, demonstrate an ability to compensate for their acute chronic or acute on-chronic condition? This is an important consideration, as the compensatory mechanisms can often go a long way to stabilizing a critically ill patient. We'll come back to this in a little bit more detail later in the tutorial. This knowledge will help to then consider the most appropriate treatment options for your patient. Let's go through the elements of the ABG panel, what they represent, along with the normal values. First is the pH, which, as we all know, measures the acidity or alkalinity of the blood. This result to me tells most of the story, right? It's the bottom line. It defines whether you have a real problem, an acidemia or an alkalemia. And based on how far from normal your value is, it can suggest just how significant the problem is. The normal value for pH is 7.35 to 7.45. Most patients tolerate variations in pH from 7.30 up to as high as 7.50 with little or no consequence. The next reported result is the partial pressure of carbon dioxide that is dissolved in the plasma of the blood. This is controlled by the respiratory system and functions as an acid in the blood. The normal value for carbon dioxide is 35 to 45 millimeters to mercury. Next is the partial pressure of oxygen. This measures the amount of oxygen dissolved in the plasma of the blood. This is different from the oxygen saturation, and we'll get into that in just a bit when we talk about oxygenation. Normal values for PaO2 are between 80 and 100 millimeters of mercury. But of course, we all know in critical care that this is not always the goal for our patients. This is a perfect example of understanding your patient's underlying physiology and setting a balanced goal that is individualized for your patient. An example of this could be the COPD patient that is mechanically ventilated. It's really easy to get the PaO2 value into normal range, but of course, this could be somewhat limiting when you're attempting to liberate the patient from the ventilator. Next is bicarb. This is the measure of the concentration of bicarbonate ions found in the plasma. The bicarb ions function as a base and are regulated by the kidneys. This is considered the metabolic parameter. Normal values for bicarb are 22 to 26. Finally, we have the SaO2, or oxygen saturation. This measures the amount of oxygen bound to hemoglobin and is reported in percentage terms. Normal values are 95 to 100%. In the ICU setting, we are generally tolerate measures of greater than 92% and sometimes as low as 88% in a very small subset of our patients. So let's talk a moment about the two elements of the ABG panel that deal with the oxygenation and understand what the differences are and how to use them. These parameters, as I just introduced, are the SaO2 and the PaO2. 97% of oxygen found in the blood is bound and carried by the red blood cell. This is measured as the O2 sat. We display this parameter continuously at the bedside to assess our patient's oxygenation through the oximeter. The lab reports a direct measure of this in the ABG result. 3% of the remaining oxygen is dissolved in the plasma and is measured as the partial pressure of oxygen, or PaO2. Normal values, as we already determined, without consideration for disease states, is greater than 95%. Of course, we all know this, and we feel a sense of reassurance when our patient's bedside sat records over 95%. Conversely, we should all feel a certain degree of trepidation when we see our SATs below 90%, with, of course, the previous mentioned exceptions. SATs below 90% are almost always an indication of hypoxemia and a need for immediate attention. So let's look at the relationship between PaO2 and oxygen saturation. As oxygen moves by diffusion from the lungs to the blood, it dissolves and also combines with hemoglobin. When the PaO2 is high, it quickly combines with hemoglobin until it becomes completely saturated at 100%. Once saturated, the measure of dissolved oxygen in the blood, though, can continue to rise if the patient is placed on supplemental oxygen. We see this often after we intubate patients and initially place them on 100% oxygen. We get a reassuring SAT of 95% or greater and usually see an elevated PaO2 on our first gas, as we are over-oxygenating the patient. This is appropriate for immediate peri-intubation stabilization, but as clinicians, we need to understand that if we are providing supplemental oxygen for our patients, that SATs over 95 may indicate that we are over-oxygenating, and we should feel compelled to reduce the supplemental oxygen in line with our treatment goals. So, reassurance is good, but more isn't necessarily better.
Let's take a couple of minutes to relate the SaO2 and the PaO2 to the oxyhemoglobin dissociation curve. We know that the SaO2 and the PaO2 are represented by the S-shaped curve and that certain physiological conditions shift that curve to the right or the left to promote or inhibit the release of oxygen that is bound to hemoglobin in the red blood cell.
When the oxyhemoglobin dissociation curve shifts to the right, it indicates a decreased affinity for oxygen and more readily releases the oxygen into the blood for cellular consumption. So think of the shift to the right as releasing oxygen to the cells. The physiological conditions that promote a right shift include acidemia, increased body temperature, and increased partial pressure of carbon dioxide. Now, on the other hand, when the oxyhemoglobin dissociation curve shifts to the left, this indicates an affinity to oxygen, inhibiting the release of oxygen from hemoglobin. The physiological states that cause the left shift include alkalemia, decreased body temperature, and a decrease in the partial pressure of carbon dioxide. So that covers the ABG parameters that reflect oxygenation. Now let's move on to the PaCO2. The partial pressure of carbon dioxide is related to the amount of CO2 that is being produced by the cells of the body. The PaCO2, as mentioned earlier, is regulated by the lungs and functions as an acid in balancing the pH. Remember, this is a respiratory parameter. Changes in the PaCO2 occur rapidly and impact the measured pH. Now, let's look at how PaCO2 falls below the normal stated values and what happens to the acid-base balance. Remember, I mentioned that the PaCO2 functions as an acid, so when patients overventilate for whatever reason, or we do this for them when they are on mechanical ventilation, the PaCO2 falls and the balance of acids drop, and the patient can develop an alkalosis. What are some of the conditions that cause a patient to overventilate? One is anxiety or pain. Another is anemia. This is largely a result of the reduction in O2 carrying capacity and hypoxemia. And also pulmonary embolism. Here again as a result of inadequate oxygenation. What happens when the PaCO2 rises? The patient has inadequate ventilation, unable to blow off CO2 that has accumulated in the blood, and it flips the balance of the pH towards acidosis. So some of the conditions that interfere with ventilation, causing CO2 to rise and acids to accumulate, include airway obstruction, drug overdose, impaired chest expansion. I think this is a big one that we often overlook in our patients. For example, the obese patient who is not sitting upright and has to overcome the counterpressure of an obese abdomen on the diaphragm. It results in small tidal volumes and reduced minute ventilation, or basically hypoventilation. Other examples include pleuritic chest pain or the pain related to chest tube placement. Also, conditions that cause a decrease in muscle strength leading to hypoventilation, like myasthenia gravis or poliomyelitis and Guillain-Barré syndrome. The other more common one we see here is prolonged mechanical ventilation and sedation. Patients in an ICU setting can get deconditioned relatively quickly, and this can add vent days. One way to offset this is to get them out of bed as early as possible, do spontaneous breathing trials daily, and limit sedation whenever possible. Now let's move over from the acids to the bases. The metabolic parameter that works to oppose the acids to maintain pH balance is the bicarb. The kidneys essentially function to regulate acid-base balance by retaining or excreting bicarb. Unlike the respiratory system's ability to rapidly regulate the CO2, the changes in bicarb take several hours to days to regulate in patients with normal renal function. Now, let's look at what happens to pH balance when bicarb falls outside of normal range. Understanding that bicarb functions as a base, a decrease in this element will result in an acidosis. So a bicarb of less than 22 milliequivalents that results from a gain of acids or a loss of base will cause a metabolic acidosis. Some conditions that will result in a metabolic acidosis include ingestion of acids, or an increase in acid production such as hypermetabolic states, and of course conditions that we see in our ICU over and over again, and that is lactic acidosis and shock. DKA is another familiar one. But of course, you wouldn't treat this with bicarb. You would aim your treatment with the resolution of the underlying problem of glucose metabolism and give insulin and IV fluids. Starvation and alcohol could also result in a metabolic acidosis. And of course, another common condition for us in the ICU setting is impaired renal function causing impairment in acid excretion. And finally, is hypovolemia. Another cause of metabolic acidosis is the loss of bicarbonate through the GI tract. So diarrhea is a common culprit here. Let's consider what happens when bicarb is in excess of 26 milliequivalents due to a gain of base or a loss of fixed acids. Here, your patient will wind up with a metabolic alkalosis. Some conditions causing a metabolic alkalosis include the loss of acids through the upper GI tract. So vomiting and NG tube suctioning can cause this. Renal losses, for example, diuretics, hypovolemia, hypochloremia, which is the chloride being one of the larger negative ions in the blood, or hypokalemia. Other considerations for metabolic alkalosis include excessive ingestion of bicarbonate antacids, bicarb drips, and the citrate load that results from massive transfusions. Now that we've talked about the primary determinants of acid-base balance, let's go back to the pH. We know that this is the parameter that indicates the acid-base balance of the blood. If your patient's pH is below 7.35, they demonstrate an excess of acids, which creates an acidemia. If your patient's pH is above 7.45, the balance is tipped in the opposite direction and there is an excess of base resulting in an alkalemia. Now, an acidemia and an alkalemia are not the same thing as an acidosis and an alkalosis. The easiest way to remember this is to recognize that an acidemia and an alkalemia are assessments of the blood pH, and the acidosis and the alkalosis are the physiological conditions that actually cause the acidemia and the alkalemia. So bringing this back to the lab parameters, the pH determines if a patient is acidemic or alkalemic, and it's the PaCO2 and the bicarb that speak to the process of the development of the acidosis or alkalosis. It's not uncommon to hear these terms thrown around, but they're not interchangeable. Okay, now that we've reviewed all the fundamental elements of the blood gas and the physiological principles that drive their results, I'd like to help you to develop a systematic approach to interpret these values. The first step is to look at the pH and understand if your patient has an acidemia, an alkalemia, or a normal acid-base balance. Now, if the pH falls within the normal limits, you're then charged with evaluating the respiratory and metabolic elements to determine if they are outside of normal limits to maintain the body pH. This physiology is referred to as compensation or compensated. Now, how do you know if your patient's normal pH is not compensated? It's simple. Just check your PaCO2 and your bicarb, and if they're normal, then there's no compensation going on and you've got a normal blood gas. The second step is to take a look at the partial pressure of carbon dioxide. Remember, this is an acid, so if the value is below 35, the effect will be a respiratory alkalosis. If the value is above 45, the effect will be a respiratory acidosis. While you're learning this approach, when you begin to use this process, it may be helpful just to label this parameter to support your interpretation. Now to step 3, look at the bicarb. A bicarb below 22 will generate a metabolic acidosis, and a bicarb above 26 will cause a metabolic alkalosis. And go ahead and label the parameter. In step 4, you want to identify the origin of the acid-base balance as either respiratory or metabolic. So, is the partial pressure of carbon dioxide high, low, or normal? Is there an alteration in the bicarb? Is it high, low, or normal? Now, evaluate this against your pH. Sometimes this can be a bit confusing because you could have a mixed bag. In other words, altered pH, altered PaCO2, and an altered bicarb. One trick I found to help simplify this is to match the pH with a respiratory or metabolic parameter that correlates. So, for sake of argument, let's say you have a pH of 7.30 and a partial pressure of carbon dioxide of 70 and a bicarb of 28. The pH is acidemic, so I would match the respiratory element as it's demonstrating an acidosis, right? It's the reduction in ventilation that is a primary acid-base disturbance. The bicarb represents a mild compensatory drive, so without it, your patient would wind up with a more profound acidemia. In step 5, you want to figure out if your patient is in compensation, just like we did with the bicarb. The simple way to do this is to look at the pH and find the respiratory or metabolic element that is in opposition to the pH. This will determine if there is any compensation and where it's coming from. So, just to review, compensated means a normal pH with an abnormal respiratory and/or metabolic parameter. Conversely, an uncompensated blood gas has an abnormal pH and an abnormal respiratory and/or metabolic parameter. Finally, not to confuse matters too much, but you could see partial compensation. This would look like a slightly abnormal pH with abnormal respiratory and/or metabolic parameters. I added this table because it helps to see in one snapshot what we've been talking about in terms of evaluating your acid-base parameters against your pH and how you might label them to accurately interpret your blood gas. So the values in the middle of the screen fall within normal limits. The values to the left fall below normal limits, and for the respiratory element, it creates an alkalosis. But for the bicarb, it creates an acidosis. Now, on the right side, these values fall above normal range, and you can appreciate the opposite effect on your blood gas results. Step 6 is a bit more simple, and that's looking at your oxygen parameters to determine whether your patient is hypoxemic. Determining whether a patient is hypoxemic or not is relatively simple, right? If they fall above 80, then they're not hypoxemic. If they fall below, well, then they are. I think the challenge, though, is to understand what's causing the hypoxemia and looking to treat that. More often than not, it's easier to just crank up the oxygen, improve our numbers, in lieu of solving the active issue. So what I would encourage you to do when you're out there caring for your patients, if you encounter hypoxemia, try and understand, what causes the patient's oxygen level to drop in the blood, and try and chase after that rather than just turning up the oxygen, which of course may be necessary. On another side note, this may sound fairly simple, but I think it bears mentioning. Be certain that your external bedside monitoring devices are providing accurate information prior to accepting a correlation of your SaO2 and your SpO2 before you initiate treatment for hypoxemia. And as mentioned earlier, while you're searching for and treating the underlying cause of your patient's hypoxemia, you may need to increase the FiO2 transiently to maintain oxygenation. Some considerations to improve oxygenation could be pulmonary hygiene in the way of suctioning or chest physical therapy, deep breathing and coughing, diuresis, position changes, PEEP, and respiratory treatments. The final step in blood gas interpretation is putting it all together in the form of a summary statement. Your statement should lead with compensated, uncompensated, or partially compensated. Follow this with the physiological assessment being respiratory or metabolic, and acidosis or alkalosis. Complete your statement with the oxygenation assessment. Okay, now let's put it all together and review a few ABGs. The first one shows an elevated pH, or alkalemia. The PaCO2 is low and the bicarb is normal. So we have an uncompensated respiratory alkalosis with normal oxygenation. Make sense? Look at the second one. We have a low pH, or an acidemia, with a high PaCO2 and a normal bicarb. So again, the patient is uncompensated, with the respiratory parameter matching the pH, or with an acidosis. The partial pressure of oxygen is low, so my summary statement would be an uncompensated respiratory acidosis with mild hypoxemia. Starting to get easier? Look at number 3. We have a normal pH, but our CO2 and the bicarb are abnormal. Let's look at which parameter more closely matches the pH. Now the pH is below 740, so it's on the acidemic side, as is the respiratory parameter, and the PaO2 is also below normal. So here, my summary statement would be a compensated respiratory acidosis with mild hypoxemia. Now, I wouldn't bother mentioning the metabolic compensation as it's too confusing, and there's no other means for the body to provide compensation, so mentioning it is just kind of redundant and, in my opinion, a little bit confusing. Number 4, the pH is acidemic, the PaCO2 is low or alkalotic, the bicarb is acidotic, so you know that the acidemia matches the metabolic acidosis without full compensation from the respiratory system. The oxygenation is normal, so the summary statement would be, right, partially compensated as the respiratory system is offering a buffer to the acidemia. So we have a partially compensated metabolic acidosis with normal oxygenation. Take a look at number 5. Acidemic for sure, and starting to look like many of our ICU patients. A low PaCO2 and a low bicarb match up with the acidemia, with the acidosis, and you have an uncompensated metabolic acidosis with normal oxygenation despite the respiratory effort. This is a patient who most likely has multiple issues contributing to their acidemia. Now for the last one, profoundly acidemic with an elevated partial pressure of carbon dioxide and a low bicarb along with poor oxygenation. What would your summary statement say? You would be right if you said uncompensated respiratory and metabolic acidosis with hypoxemia. In this case, both the respiratory and metabolic parameters show an acidosis compounding the acidemia. All right, this concludes part 1 of the ABG certification course. I hope you found the information helpful so you can bring it to the bedside and work more collaboratively with your ICU colleagues and make a difference for your patients. Thanks for your attention.